Hello, and welcome back to another stream of Advanced Pharmacology. Today we'll talk about Chapter 19, Drugs for Epilepsy and Seizure. So, the seizure generation. Seizures are initiated by synchronous high-frequency discharge from a group of hyperexcitable neurons called a focus. A focus may result from several causes, including a congenital defect, hypoxia at birth, head trauma, brain infection, stroke, cancer, and genetic disorders. Seizures occur when discharge from the focus spreads to other brain areas, thereby recruiting normal neurons to discharge abnormally. The overt manifestation of any particular seizure disorder depends on the location of the seizure focus and the neuronal connection to that focus. The connection to the focus determines the brain areas to which seizure activity can spread. So, types of seizures. Seizures can be divided into two broad categories: a partial focal seizure and a generalized seizure. In partial seizures, seizure activity undergoes a very limited spread to adjacent cortical areas beyond the focus. In generalized seizures, focal seizures activity is conducted widely throughout both hemispheres. As a rule, partial seizures and generalized seizures are treated with different drugs. So here at this table is an excellent spot to hit pause so you can review which kind of drugs you would use for either a partial or a primary generalized seizure. Partial seizures. Partial seizures fall into three groups: simple partial seizures, complex partial seizures, and partial seizures that evolve into secondary generalized seizures. Simple partial seizures. These seizures manifest with discrete symptoms that are determined by the brain region involved. Therefore, the patient may experience discrete motor symptoms, such as a twitching thumb, sensory symptoms like local numbness, auditory, visual, or olfactory hallucinations, autonomic symptoms such as nausea, flushing, salivation, urinary incontinence, or psychoillusionary symptoms. You have feelings of unreality, fear, or depression. Simple partial seizures are distinguished from partial seizures in that there is no loss of consciousness. These seizures persist for 20 to 60 seconds. Complex partial seizures. These seizures are characterized by impaired consciousness and lack of responsiveness. At seizure onset, the patient becomes motionless and stares with a fixed gaze. This state is followed by a period of automatism in which the patient performs repetitive, purposeless movements, such as lip smacking or hand wringing, and seizures can last anywhere between 45 to 90 seconds. Secondarily generalized seizures. These seizures begin as a simple or complex partial seizure, but eventually evolve into a generalized tonic-clonic seizure. Consciousness is lost. These seizures can last 1 to 2 minutes. Generalized seizures. Generalized seizures may be convulsive or non-convulsive. As a result, they produce immediate loss of consciousness. The major generalized seizures are discussed briefly later. Tonic-clonic seizures. In tonic-clonic seizures, formerly known as grand mal seizures, neuronal discharge spreads throughout both hemispheres of the cerebral cortex. These seizures manifest as major convulsions, characterized by a period of muscle rigidity, followed by synchronous muscle jerking. Tonic-clonic seizures often cause urination, but not defecation. Convulsions may be preceded by a loud cry, caused by forceful expiration of air across the vocal cords. Tonic-clonic seizures are accompanied by a landmark impairment of consciousness and are followed by brief periods of central nervous depression, referred to as the postictal state. The seizure itself typically lasts 90 seconds or less. Absence seizure. An absence seizure is characterized by the loss of consciousness for a brief time, 10 to 30 seconds. Seizures usually involve mild, symmetrical motor activity, but may occur with no motor activity at all. The patient may experience hundreds of these absence seizures a day. Absence seizures occur primarily in children and usually cease during the early teen years. Atonic seizures. These seizures are characterized by a sudden loss of muscle tone. If seizure activity is limited to the muscle of the neck, head drop occurs. However, if the muscles of the limbs and trunk are involved, a drop attack can occur, causing a patient to suddenly collapse. Atonic seizures occur mainly in children. Myoclonic seizures. These seizures consist of sudden muscle contraction that lasts for 1 second. Seizure activity may be limited to one limb, or it may be involved in the entire body. Your status epilepticus. Status epilepticus, or SE, is defined as a seizure that persists for 15 to 30 minutes or longer, or a series of recurrent seizures during which the patient does not retain consciousness. There are several types of status epilepticus, including generalized, convulsive, absence, and myoclonic. Febrile seizures. Fever-associated seizures are common among children ages 6 months to 5 years. Febrile seizures typically manifest as generalized tonic-clonic convulsions of short duration. Children who experience these seizures are not at high risk for developing epilepsy later in life. Mixed seizures. The Lennox-Gastaut syndrome. Lennox-Gastaut syndrome is a severe form of epilepsy that usually develops during the preschool years. The syndrome is characterized by the developmental delay and a mixture of partial and generalized seizures. Seizure types Seizure types include partial, atonic, tonic, generalized tonic-clonic, and atypical absence. In children with Lennox-Gastaut syndrome, seizure can be very difficult to manage. So how do antiepileptic drugs work? We have long known that the AEDs can suppress discharge of neurons within a seizure focus and suppress propagation of seizure activity from the focus to the other areas of the brain. However, until recently, we didn't know how these effects were achieved. It now appears that nearly all AEDs act through 5 basic mechanisms: the suppression of the sodium influx, suppression of the calcium influx, the promotion of potassium efflux, a blockade of receptors for glutamate, and finally the potentiation or increase of the gamma-aminobutyric acid or GABA. Categorization of AEDs by mechanism of action, when known, will be displayed in this following box. So here is an excellent spot to hit pause so you know the different categories of drugs and where they fall into, whether they affect your sodium influx, calcium influx, your potassium efflux, or GABA activity. So we'll start off with the first one, the suppression of sodium influx. Before discussing how AED's actions, we need to review the sodium channel physiology. Neuronal action potential are propagated by an influx of sodium through the sodium channel, which are gated pores in the cell membrane that control sodium entry. For sodium influx to occur, the channel must be in an activated state. Immediately after sodium entry, the channel goes into an inactivated state, during which further sodium entry is prevented. Under normal circumstances, the inactive channel very quickly returns to an activated state, thereby permitting more sodium entry and propagation of another action potential. Several of these AEDs, including phenytoin, carbamazepine, and lamotrigine, reversibly bind to sodium channels while they are in the inactivated state and therefore prolong channel inactivation. By delaying the return to the active state, these drugs decrease the ability for neurons to fire at a high frequency. As a result, seizures that depend on this high-frequency discharge are being suppressed. Suppression of the calcium influx. In axon terminals, influx calcium through voltage-gated calcium channels promotes the transmitter release. Therefore, drugs that block these calcium channels can suppress this transmission. Ethosuximide acts by this mechanism. The promotion of potassium efflux. During an action potential, influx of sodium causes neurons to depolarize, and then efflux of potassium causes neurons to repolarize. 1-AED, ezogabine, or retigabine act on voltage-gated potassium channels to facilitate the potassium efflux. This action is believed to underlie the drug's ability to slow the repetitive neuronal firing and therefore provide seizure control. The antagonism of glutamate. Glutamic acid, or glutamate, is the primary excitatory transmitter in the CNS. The compound works through two receptors, the N-methyl-D-aspartate, or NMDA, receptors and the alpha-amino 3 hydroxy 5-methyl-4-isoxazole propionic acid, or AMPA receptors. Perampanel is an AMPA glutamate receptor antagonist. Two other drugs, felbamate and topiramate, block the actions of glutamate at NMDA receptors and therefore suppress neuronal excitation. Potentiation of gamma-aminobutyric acid. Several AEDs potentiate the actions of GABA, an inhibitory neurotransmitter that is widely distributed throughout the brain. By augmenting the inhibitory influence of GABA, these drugs decrease neuronal excitability and thereby suppress seizure activity. Drugs increase the influence of GABA by several mechanisms. Benzodiazepines and barbiturates enhance the effects of GABA by mechanisms that involve direct binding to GABA receptors. Gabapentin promotes GABA release. Tiagabine inhibits GABA reuptake, and vigabatrin inhibits the enzyme that degrades GABA, and thereby all increases GABA availability. So, the basic therapeutic consideration, the therapeutic goal and treatment options. The goal in treating epilepsy is to reduce seizures to an extent that enables the patient to live a normal or nearly normal life. Ideally, treatment should eliminate seizures entirely. However, this may not be possible without causing intolerable side effects. Therefore, we must balance the desire for complete seizure control against the acceptability of side effects. Epilepsy may be treated with drugs or with non-drug therapies. As noted, drugs can benefit 60 to 70% of patients. This means that of the 2.9 million Americans with epilepsy, between 870,000 and 1,160,000 cannot be treated successfully with drugs. For these people, non-drug therapy may well help. Three options exist: neurosurgery, vagus nerve stimulation, and the ketogenic diet. Of the three, neurosurgery has had the best success rate, but vagus nerve stimulation is used most widely. The diagnosis and drug selection, therefore. Control of seizure requires proper drug selection. As indicated in the prior table 19.1, many AEDs are selective for specific seizure control disorders. Phenytoin, for example, is useful for treating tonic-clonic and partial seizures, but not in absence seizures. Conversely, ethosuximide is active against absence seizures, but not against tonic-clonic or partial seizures. Only one drug, valproic acid, appears effective against practically all forms of epilepsy. Because most AEDs are selective for certain seizure disorders, effective treatment requires a proper match between the drug and the seizure. To make this match, the seizure type must be accurately diagnosed. Making a diagnosis requires physical, neurologic, and laboratory evaluations along with a thorough history. The history should determine the age at which seizures began, the frequency and the duration of seizure events, precipitating factors, and times when the seizures occur. Physical and neurologic evaluations may reveal signs of head injury or other disorders that could underlie seizure activity. Although in many patients the physical and neurologic evaluation may be normal, an electroencephalogram is essential for diagnosis. Other diagnostic tests that may be employed include a CAT scan, positron emission tomography, and a magnetic resonance image. So CT scans, PET scans, and MRIs. Pharmacologic management with AEDs is highly individualized. Very often, patients may try several AEDs before a regimen that is both effective and well tolerated can be established. Initial treatment should be done with just one AED. If this drug fails, it should be discontinued and a different AED should be trialed. If the second drug fails, two options are available: treatment with a third AED alone, or treatment with a combination of AEDs. So, drug evaluation. After an AED has been selected, a trial period is needed to determine its effectiveness. During this time, there is no guarantee that seizures will be controlled. Until seizure control is certain, the patient should be warned not to participate in driving and any other activities that could be hazardous should a seizure occur. Maintenance of a seizure frequency chart is important. The chart should be kept by the patient or a family member and should contain a complete record of all seizure events. This record can be used to help guide the provider in optimizing a pharmacologic management. During the process of drug evaluation, adjustments in dosage are often needed. No drug should be considered ineffective until it has been tested in sufficiently high doses and for a reasonable time. Knowledge of plasma drug levels can be a valuable tool for establishing dosage and evaluating the effectiveness of a specific drug. Monitoring plasma drug levels. Safe and effective levels have been firmly established for most AEDs. Monitoring these levels can help guide dosage adjustment. So here's an excellent spot to hit pause so you can see the clinical pharmacology of the oral anti-epileptic drugs. So I'll see if I can put this in spaces where it makes sense to pause. There we go. Monitoring plasma drug levels is especially helpful when treating major convulsion disorders. Because these seizures can be dangerous and because delay of therapy may allow the condition to worsen, rapid control of seizures is desirable. However, because these seizures occur infrequently, a long time may be needed to establish control if clinical outcome is relied on as the only means of determining an effective dosage. By adjusting the initial doses of the basis of plasma drug level, we can readily achieve drug levels that are likely to be effective, thereby increasing our chances of establishing control quickly. Measurements of plasma drug levels are less important for determining effective dosage for absence seizures. Because absence seizures occur very frequently, observation of the patient is the best means for establishing an effective dosage. If seizures stop, dosage is sufficient. If seizures continue, it is likely that more drug is needed. In addition to serving as a guide for dosage adjustment, knowledge of plasma drug levels can serve as an aid, monitoring patient adherence, determining the cause of lost seizure control, and identifying causes of toxicity, especially in patients taking more than one drug. Promoting patient adherence. Epilepsy is a chronic condition that requires regular and continuous therapy. As a result, seizure control is highly dependent on patient adherence. In fact, it is estimated that non-adherence accounts for about 50% of all treatment failures. Accordingly, promoting adherence should be the priority of all members of the healthcare team. Measures can help include the following: educating patients and families about the chronic nature of epilepsy and the importance of adhering to the prescribed regimen, monitoring plasma drug levels to encourage and evaluate adherence, And finally, deepening patient and family involvement by having them maintain a seizure frequency chart. Withdrawing anti-epileptic drugs. Some forms of epilepsy undergo spontaneous remission, and therefore discontinuing treatment may eventually be appropriate. Unfortunately, there are no firm guidelines to indicate the most appropriate time to withdraw an AED. However, after the decision to discontinue treatment has been made, agreement does exist on how drug withdrawal should be accomplished. The most important rule is that AED's withdrawal should occur slowly, a period of at least 6 weeks to several months. Failure to gradually reduce the dosage is a frequent cause of SE. If a patient is taking two drugs to control seizures, they should be withdrawn sequentially, not simultaneously. Suicide risk with an anti-epileptic drug. In 2008, the FDA warned that all AEDs can increase suicidal thoughts and behaviors. However, data gathered since '08 suggests that the risk may be lower than previously believed and may apply only to certain AEDs. Since the FDA issued this warning, other large studies have been conducted to clarify the relationship between AEDs and suicidality. Unfortunately, these studies have yet yielded conflicting results. Nonetheless, they do suggest three things. First, only some AEDs, especially topiramate and lamotrigine, are likely to increase suicidal thoughts. Not all AEDs are warned by the FDA. Second, the risk for suicidal behavior may be related more to the illness than the medication. By analyzing data on at least 5 million patients plus, researchers in the US and the UK found that the AEDs produced a small increase in suicidal behavior in patients who had depression, but did not increase suicidal behavior in patients with epilepsy or bipolar disorder. And third, even AEDs do not promote suicidal ideation. AEDs related suicide attempts and completed suicides were very rare. Given the uncertainty regarding AEDs and suicidal ideation, what should the clinician therefore do? Because epilepsy itself carries a risk for suicide, and because patients with epilepsy often have depression or anxiety, prudence dictates screening all patients for suicide risk, whether or not AEDs increase that risk. In addition, after treatment begins, all patients should be monitored for increased anxiety, agitation, mania, and hostility, signs that may indicate the emergence or worsening of depression and an increased risk for suicidal thoughts or behaviors. Patients, families, and caregivers should be alerted to these signs and be advised to report them immediately. Finally, two AEDs, topiramate and lamotrigine, should be used with special caution, given their significant association with suicidal ideation. So, classifications of anti-epileptic drugs. The AED can be grouped into two major categories: traditional AEDs and newer versions of AEDs. The traditional group has 7 major members. The group of newer AEDs has 13. As shown in the following table 19.3, both groups have their advantages and disadvantages. An example: clinical experience with the older AEDs is more extensive than with newer ones, and the older drugs therefore cost also less. Both facts make the older drugs more attractive. However, the older AEDs also have drawbacks, including troublesome side effects and complex drug interactions. Of course, drugs in both groups appear equally effective, although few direct comparisons have been made. The bottom line: neither group is clearly superior. Therefore, when selecting an AED, drugs in both groups should be considered. So here's a good spot to hit pause so you see the comparison of traditional and newer drug anti-epileptic drugs. Traditional anti-epileptic drugs. The traditional AEDs have been in use for decades. Because of this extensive clinical experience, the efficacy and therapeutic niche of the traditional AEDs are well established. As a result, these drugs are prescribed more widely than the newer AEDs. Although familiarity makes the traditional AEDs appealing, These drugs do have drawbacks. In general, they are less well tolerated than the newer AEDs, and they pose a greater risk for developing to the developing fetus. Furthermore, owing to the effects of drug metabolizing enzymes, they have complex interactions with other drugs, including other AEDs. In the discussion that follows, we focus on the major traditional AEDs. They are phenytoin, fosphenytoin, carbamazepine, valproic acid, ethosuximide, phenobarbital, and primidone. So here are our prototype drugs. A good spot again to hit pause if you're unfamiliar with any of the traditional agents and some of the newer ones. So we'll jump right into phenytoin. Phenytoin, also known as Dilantin, is our most widely used AED, despite having tricky kinetics and a troublesome side effect. The drug is active against partial seizures as well as primarily generalized tonic-clonic seizures. Dilantin is of the historical importance, as in that it was the first drug to suppress seizures without depressing the entire CNS. Dilantin is heralded the development of selective medications that could treat epilepsy while leaving most CNS functions undiminished. So how does it work? At the concentrations achieved clinically, Dilantin causes selective inhibition of sodium channels. Specifically, the drug slows the recovery of sodium channels from the inactive state back to the active state. As a result, entry of sodium into neurons is inhibited, and the action potentials are suppressed. Blockade of sodium entry is limited to neurons that are hyperactive. So as a result, the drug suppresses the activity of seizure-generating neurons while leaving the healthy neurons unaffected. Its pharmacokinetics. Dilantin has unusual pharmacokinetics that must be accounted for in therapy. Absorption varies substantially among patients. In addition, because of saturation kinetics, small changes in dosage can produce disproportionate large changes in serum drug levels. As a result, a dosage that is both effective and safe is difficult to establish. Its absorption. Absorption varies between the different oral formulations of Dilantin, with the oral suspension and chewable tablet absorption is relatively fast, whereas with the extended release capsules, absorption is delayed and prolonged. In the past, there was concern that the absorption also varied between the preparations of Dilantin made by different manufacturers. However, it is now clear that all FDA-approved equivalent products all have an equivalent bioavailability. So as a result, switching from one brand of Dilantin to another produces no more variability than switching between different lots of Dilantin produced by the same manufacturer. Its metabolism. The capacity of the liver to metabolize Dilantin is very limited. Doses of Dilantin need to produce therapeutic effects are only slightly smaller than the doses needed to saturate the hepatic enzymes that metabolize Dilantin. If Dilantin is administered in doses only slightly greater than those needed for therapeutic effect, the liver's capacity to metabolize the drug will be overwhelmed, causing plasma levels of Dilantin to rise dramatically. This unusual relationship between dosage and plasma level is illustrated in Figure 19.1a. As you can see, after the plasma levels have reached the therapeutic range, small changes in dosage produce large changes in plasma level. As a result, small increases in dosage can cause toxicity, and small decreases can cause therapeutic failure. This relationship makes it very difficult to establish and maintain a dosage that is both safe and effective. The relationship between dosage and plasma levels that exist for most drugs is detailed in Figure 19.1b. As indicated, this relationship is linear in contrast to the nonlinear relationship that does exist for Dilantin. Accordingly, for most drugs, if the patient is taking doses that produces plasma levels that are within the therapeutic range, small deviations from the dosage produce only small deviations in plasma drug levels. Because of this relationship, with most drugs, it is relatively easy to maintain plasma levels that are safe and effective. Because of saturation kinetics, the half-life of dilantin varies with dosage. At low doses, the half-life is relatively short, only about 8 hours. However, at higher doses, the half-life starts to get prolonged, and in some cases may last up to 60 hours. At higher doses, there is more drug present than the liver can process, so as a result, the metabolism is delayed, which is what causes the half-life to increase. Its therapeutic use, therefore. In epilepsy, dilantin can be used to treat all forms of epilepsy, except absence seizures. The drug is especially effective against tonic-clonic seizures and is the drug of choice for treating seizures in adults and older children. Carbazamine is preferred to dilantin for treating tonic-clonic seizures in young children. Although dilantin can be used to treat simple and complex partial seizures, the drug is less effective against these seizures than against tonic-clonic seizures. Dilantin can be administered via IV injection to treat generalized convulsive SE, but other drugs are preferred. Cardiac dysrhythmias. Dilantin is active against certain types of dysrhythmias. Antidysrhythmic application is discussed in Chapter 41. Adverse effects on the CNS. Although dilantin acts on the CNS in the relatively selective fashion to suppress a seizure, the drug can still cause CNS side effects, especially when the dosage is excessive. At a therapeutic level of 10 to 20 micrograms per ml, sedation and other CNS effects are considered mild. At plasma levels, though, above 20 micrograms per ml, toxicity can occur. Nystagmus is relatively common. Other manifestations of excessive dosage include sedation, ataxia, diplopia, and cognitive impairment. Gingival hyperplasia. Gingival hyperplasia is characterized by the swelling, tenderness, and bleeding of the gums. In extreme cases, patients require gingivectomy. Gingival hyperplasia is seen in about 20% of patients who do take dilantin. Can risk be reduced? Possibly. Risk may be minimized by good oral hygiene, including dental flossing and gum massage. Patients should be taught these techniques and be encouraged to practice them. Supplemental folic acid is often recommended for the adverse effects based on the studies that demonstrated that the supplemental folic acid reduces gingival overgrowth. However, other research did demonstrate this benefit. A subsequent Cochrane review established that only 15 of the studies met inclusion criteria, and even those had issues with methodologic quality. So their conclusion was that current evidence is insufficient to support the use of folic acid to prevent gingival hyperplasia, so additional randomized control trials are still needed. Again, this is older, so take that with a grain of salt. Dermatologic effects. Between 2 and 5% of patients develop the morbilliform or measles-like rash. Rarely, morbilliform rash progresses to much more severe reactions, including the Stevens-Johnson syndrome or a toxic epidermal necrolysis. The FDA labeling warns that the risk for developing Stevens-Johnson syndrome or TEN is strongly associated with a genetic mutation, also known as the human leukocyte antigen, HLA-B1502, which occurs almost exclusively in people of Asian descent. For this reason, dilantin should not be prescribed for patients who have known to have this mutation. Its effects in pregnancy. Dilantin is a teratogen. It can cause cleft palate, heart malformations, and fetal hydantoin syndrome, characterized by the growth deficiency, motor or mental deficiency, microcephaly, craniofacial distortion, positional deformities of the limbs, hypoplasia of the nails and fingers, and impaired neurodevelopment. Because of all of these effects, dilantin is classified in the FDA pregnancy risk group category D and should not be used during pregnancy, and only if safer alternatives are not effective. and if the benefits of seizure control are deemed to outweigh the risk to the fetus. Dilantin can decrease the synthesis of vitamin K-dependent clot factors and can therefore cause bleeding tendencies in newborns. The risk for neonatal bleeding can be decreased by giving a prophylactic vitamin K to the mother for 1 month before and during the delivery and to the infant immediately after the delivery. Cardiovascular effects. When dilantin is administered by IV to treat SE, cardiac dysrhythmias and hypotension may result. These dangerous responses can be minimized by injecting dilantin no more than 50 milligrams per minute. So, it's black box warning, therefore, of dilantin and fosphantoin, or Cerebex. When administered IV at rates exceeding 50 milligrams per minute in adults, or at the slower rate of either 1 to 3 milligrams per kilogram per minute, or 50 milligrams per minute in children, dilantin can cause severe hypotension and cardiac dysrhythmias. Cardiac monitoring should be in place prior to administration. Other adverse effects. Hirsutism can be a disturbing response, especially in a young woman. Interfering with vitamin D metabolism may cause rickets and osteomalacia. Interference with vitamin K metabolism can lower prothrombin levels, therefore causing bleeding tendencies in newborns. Very rarely, liver damage may occur, probably because of drug allergy. Other drug interactions. Dilantin interacts with a large number of drugs. The more important interactions are discussed here. So, interactions resulting from induction of hepatic drug metabolizing enzymes. Dilantin stimulates the synthesis of hepatic drug metabolizing enzymes. So as a result, dilantin can decrease the effects of other drugs, including oral contraceptives, Coumadin, and glucocorticoids. Because avoiding pregnancy is desirable while taking anti-seizure medications, and because dilantin can decrease the effectiveness of oral contraceptives, the provider may need to increase contraceptive dosage, or switch to an alternative form of contraception may need to be made. Drugs that increase the plasma levels of dilantin. Because the therapeutic range of dilantin is narrow, slight increases in dilantin levels can cause toxicity. So, consequentially, caution must be exercised when dilantin is used with other drugs that may increase its level. Drugs that we do know that does that include diazepam, isoniazid, and cimetidine, and when drinking alcohol. These agents increase dilantin levels by reducing the rate at which dilantin is metabolized. Valproic acid elevates levels of free dilantin by displacing dilantin from its binding site on the plasma protein. And then the opposite end, drugs that decrease plasma levels, such as your carbamazepine, your phenobarbital, and alcohol, can accelerate the metabolism of dilantin, therefore decreasing its level, so breakthrough seizures may result. Your CNS depressants. The depressant effect of alcohol, barbiturates, and other CNS depressants will add to those of dilantin. Advise patients to avoid alcohol and all other drugs with CNS depressing actions. Its preparation, dosage, and administration. Preparations. There are a large number of dilantin products on the market. Dilantin products made by different manufacturers have equivalent bioavailability. Therefore, although switching between products from different manufacturers was a concern in the past, it is not a concern today. Dosaging. Dosing is highly individualized. Again, plasma drug levels are often monitored as an aid to establish a dosage. The dosing objective is to produce a level between 10 and 20 micrograms per ml. Levels below 10 micrograms are too low to control the seizure, while above 20 produce toxicity. Because dilantin has such a relatively narrow therapeutic range, and because of the nonlinear relationship between dilantin dosage and the phenytoin or dilantin plasma level, after a safe and effective dosage has been established, the patient should therefore adhere to it rigidly. When treatment is discontinued, dosage should be reduced gradually. The abrupt withdrawal may precipitate a seizure. Its administration. Oral preparations may cause gastric discomfort. Patients should be informed that gastric upset can be reduced by administering Dilantin with or immediately after a meal. Patients using the oral suspension should shake it well before dispensing, because failure to do so may result in an uneven dose. Which brings us to the next medication, euphosphatine, also known as Cerebex. Cerebex is a prodrug that is converted to Dilantin when metabolized. It is recommended as a substitute for oral Dilantin when the oral route is contraindicated. Because it is converted to Dilantin, the mechanism of action, therapeutic and adverse effects, and drug interactions are the same as those of Dilantin. Its pharmacokinetics. Its pharmacokinetic properties are essentially the same as Dilantin after its conversion. There are a few differences that are attributable to the prodrug in its non-hydrolyzed state. So, we'll start off by talking about its absorption. Cerebex is available for parenterally administration only. Unlike Dilantin, Cerebex may be administered by the intramuscular route. This provides an advantage in that the IV access is so that if IV access is unattainable, the drug is rapidly absorbed after an IM administration. Bioavailability is 100% using either the IM or IV route. Cerebex is rapidly hydrolyzed to Dilantin. Its conversion half-life is 15 minutes. Its distribution. Cerebex is 95 to 99% protein bound. Because it is more highly protein bound than Dilantin, protein binding with Cerebex may displace Dilantin from protein binding sites, resulting in a transient increase of free, unbound active Dilantin. Adverse effects. Adverse effects of Cerebex are the same as those for Dilantin, with one notable exception. During an IV infusion, temporary paresthesias and itching, especially in the groin area, may occur. This infusion-related reaction will resolve when the infusion rate is decreased, or within 10 minutes after the completion of the infusion. Its dosage and administration. Cerebex has a unique dosing system. Although 150 milligrams of Cerebex will hydrolyze to 100 milligrams of Dilantin, rather than using a standard milligram dosing, Cerebex is dosed in Dilantin equivalents. Using this alternative, Cerebex 1 milligram PE equals Dilantin 1 milligram. Unlike Dilantin, the IV formulation of Cerebex is compatible with standard IV solutions. When the drug is administered via IM, the full dose may need to be divided into 2 or 4 separate injections. Which brings us to the next medication. Carbamazepine, also known as Tegretol, is a cornerstone for epilepsy therapy. The drug is active against partial seizures and tonic-clonic seizures, but not absence seizures. So how does it work? Tegretol suppresses high-frequency neuronal discharge in and around seizure foci. The mechanism appears to be the same as that of Dilantin, delayed recovery of the sodium channel from their inactivated state. Its pharmacokinetics. Absorption of Tegretol is delayed and variable. Levels peak 4 to 12 hours after dosing. Overall bioavailability is about 80%. The drug distributes well to tissues. The elimination is by the hepatic metabolism. Tegretol is unusual in that its half-life decreases as therapy progresses. During the initial phase of treatment, the half-life is about 40 minutes. With continued treatment, the half-life decreases to about 15 hours. Because Tegretol, like Dilantin and phenobarbital, induces hepatic drug metabolizing enzymes. By increasing its own metabolism, Tegretol causes its own half-life to decline. Its therapeutic use, therefore, for epilepsy. Carbamazepine or Tegretol is effective against tonic-clonic, simple partial, and complex partial seizures. Because the drug causes fewer adverse effects than Dilantin and phenobarbitals, it is often preferred to these agents. Many prescribers consider Tegretol the drug of choice for partial seizures. Tegretol is not effective again against absence, myoclonic, or atonic seizures. Its therapeutic use, therefore, in bipolar disorder. It can provide symptomatic control in patients who have bipolar disorder, and is often effective in patients who are refractory to lithium. The role of Tegretol in bipolar disorder will be discussed in more detail in Chapter 26. It also has its therapeutic use for trigeminal and glossopharyngeal neuralgias. A neuralgia is a severe stabbing pain that occurs along the course of a nerve. Tegretol can reduce neuralgia associated with the trigeminal and glossopharyngeal nerve. The mechanism is unknown. It should be noted that although Tegretol can reduce pain in this specific neuralgia, it is not generally effective as an analgesic, and it's not indicated for other kinds of pain. Its adverse effects. Its adverse effects on the CNS. In contrast to Dilantin and phenobarbitals, Tegretol has minimal effects on the cognitive function. This is a primary reason for selecting Tegretol over other anti-seizure drugs. Tegretol can cause a variety of neurologic effects, including visual disturbances, ataxia, vertigo, unsteadiness, and headaches. These reactions are common during the first weeks of treatment, afflicting 35 to 50% of patients. Fortunately, tolerance usually develops with continued use, and these effects can be minimized by initiating therapy at a low dose and giving the largest portion of the daily dose during bedtime. Hematologic effects. Tegretol-induced bone marrow suppression can cause leukopenia, anemia, and thrombocytopenia. However, serious reactions are rare. Thrombocytopenia and anemia, which have an incidence rate of 5%, respond to drug discontinuation. Leukopenia, which has an incidence rate of 10%, is usually transient and it subsides even with continued drug use. Accordingly, Tegretol should not be withdrawn unless the white blood cell count drops below 3,000. Fatal aplastic anemia has occurred during Tegretol therapy. This reaction is extremely rare, having an incidence rate in 1 in 200,000. To monitor for serious hematologic effects, a CBC should be performed before treatment and periodically thereafter. Patients with pre-existing hematologic abnormalities should not use this medication. Patients should be informed about the manifestations of hematologic abnormalities and be instructed to notify their prescriber if they occur. So, the big ones to look out for would be fever, sore throat, pallor, weakness, infection, easy bruising, and petechiae. Birth defects. Tegretol is teratogenic. In humans, the drug is associated with a 2.6-fold increase in the risk for spina bifida, a neural tube defect. Because it can harm the fetus, Tegretol is classified in the FDA pregnancy risk category D, and therefore should only be used if the benefits of seizure control are deemed to outweigh the risk to the fetus. Hypoosmolarity. Tegretol can inhibit renal excretion of water, apparently by promoting the secretion of antidiuretic hormone. Water retention can reduce the osmolarity of blood and other body fluids, thereby posing a threat to patients with heart failure. Periodic monitoring of the serum sodium level should be recommended. Dermatologic effects. Tegretol has been associated with several dermatologic effects, including the morbilliform rash, photosensitivity reaction, Stevens-Johnson syndrome, and tan. Mild reactions can often be treated with prednisone or an antihistamine. Severe reactions to Stevens-Johnson syndrome and TEN necessitate the drug's withdrawal. So, it's black box warning of Tegretol. Tegretol can cause serious skin reactions, again, such as Stevens-Johnson syndrome and TEN. Fatalities may occur. The risk for the reaction is strong associated with the HLA-B1502 variant of the HLA-B gene that is found predominantly in Asian people. Aplastic anemia and agranulocytosis occurred in patients taking Tegretol. The incidence rate is 2 to 6 patients for 1 million. A major risk factor for Stevens-Johnson syndrome and TEN, again, is that HLA-B1502, a genetic variation seen in the Asian descent. Among people with the variant gene, about 5% do develop Stevens-Johnson or TEN with Tegretol. Accordingly, to reduce the risk for severe reactions, the FDA recommends that before receiving Tegretol, patients of Asian descent should be tested for the HLA-B1502. Of note, this was the first time that the FDA recommended a genetic screening for a major drug. As discussed previously, the presence of HLA-B1502 may also increase the risk for Stevens-Johnson and TEN in patients who are taking Dilantin. Accordingly, Dilantin should not be used as an alternative to Tegretol in patients with the mutation. Which brings us to drug-drug and drug-food interactions. Induction of drug-metabolizing enzymes. Carbamazepine induces the hepatic drug-metabolizing enzyme and therefore can increase the rate at which it and other drugs are inactivated. Accelerated inactivation of oral contraceptives and Coumadin is of particular concern. Your Dilantin and phenobarbital, both Dilantin and phenobarbital, induce hepatic drug metabolism. Therefore, if either drug is taken with carbamazepine, the induction of metabolism is likely to be greater than with carbamazepine alone. Accordingly, Dilantin and phenobarbital can further accelerate the metabolism of carbamazepine, thereby decreasing its effectiveness. Grapefruit juice. Again, this was discussed in majority in Chapter 4, but grapefruit juice can inhibit the metabolism of many drugs, therefore causing their plasma levels to rise. Grapefruits can increase peak and trough levels of carbamazepine by up to 40%. Advise patients to avoid grapefruit juice. Dosage and other administrations. Carbamazepine should be administered with meals to reduce gastric upset. Administering the largest portion of the daily dose at bedtime can help reduce adverse CNS effects. Carbamazepine suspension should not be administered with any other liquid formulation medicines. To minimize side effects, dosage is low initially and then increased gradually every 1 to 3 weeks until the seizure control starts to become achieved. So let's talk about valproic acid. Valproic acid, also known as Depakote, is an important AED used widely to treat all major seizure types. In addition to its use in epilepsy, valproic acid is used for bipolar disorder and migraine headaches. The nomenclature. Valproic acid is available in 3 closely related chemical forms. Valproic acid, the sodium salt of valproic acid, also known as valproate, and finally divalproex sodium, which is a combination of valproic acid plus its sodium salt. All 3 forms have identical anti-seizure actions. In this chapter, the term valproic acid is used in reference to all 3. So because there's 3 different versions of this medication, here is a table that kind of provides some small comparisons. A good spot to hit pause. The exact mechanism of valproic acid is unknown. Though several mechanisms have been suggested, most experts now believe it may augment the inhibitory influence of GABA or increase GABA concentration in the brain. Its pharmacokinetics. Depakote, or valproic acid, is readily absorbed from the gastrointestinal tract. and is widely distributed throughout the body. The drug undergoes an extensive hepatic metabolism, followed by renal excretion. Therapeutic responses are often seen at low plasma levels of 50 to 100 micrograms per ml. However, the correlation between the plasma levels and therapeutic effects is not very narrow. Therapeutic use. Seizure disorders. Depakote is considered a first-line drug for all partial and generalized seizures. In bipolar disorder, like carbamazepine, Depakote can provide symptomatic control in patients with bipolar disorder, the manic depressive illness. This application is going to get discussed in further detail in Chapter 26. In migraines, valproic acid is approved for the prophylaxis of migraine management, and that's further discussed in Chapter 23. Its adverse effects. Valproic acid is generally well tolerated and causes minimal sedation and cognitive impairment. Gastrointestinal effects are most common. Hepatotoxicity and pancreatitis are rare but serious side effects. So it has a black box warning. Valproate and valproic acid, or Depakote. Fatal hepatic failure has occurred in young children and patients with a mitochondrial disease, which are at an increased risk. Fatal and rapidly progressing pancreatitis has also occurred. Common symptoms of it include nausea, vomiting, anorexia, and abdominal pain. Valproate, or Depakote, is highly teratogenic. Neonates who survive may have major congenital malformations and a decreased mental capacity. So do not use Depakote if you are pregnant. Your gastrointestinal effects. Nausea, vomiting, and indigestion are the common but transient. These effects are most intense with formulations that are not enteric-coated. Your gastrointestinal reactions can be minimized by administering valproic acid with food and by using an enteric-coated product. Again, you'll see that in Table 19.4. Hepatotoxicity. Rarely, valproic acid has been associated with fatal liver failure. Most deaths have occurred within the first few months of therapy. The overall incidence of fatal hepatotoxicity is about 1 in 40,000. However, in high-risk patients, such as children younger than 2, receiving multiple drug therapy, the incidence is much higher, 1 in about 500. To minimize this risk for fatal liver injury, the following guidelines have been established. Don't use valproic acid in conjunction with other drugs in children younger than 2. Don't use valproic acid in patients that have a pre-existing liver dysfunction. Start by evaluating the liver function at baseline and periodically thereafter. And always inform your patients about the signs and symptoms of liver injury. Again, reduced appetite, malaise, nausea, abdominal pain, and jaundice, and instruct them to notify the prescriber if these ever start to develop. Use valproic acid or Depakote in the lowest effective dosage. So, pancreatitis. Life-threatening pancreatitis may develop again in children and adults. Some cases have been hemorrhagic, progressing rapidly from the initial symptoms to finally death. Pancreatitis can develop soon after starting therapy or after years of drug use. Patients should be informed about the signs of pancreatitis and be instructed to obtain immediate evaluation if they begin to develop. If pancreatitis is diagnosed, valproic acid should be withdrawn and an alternative medicine should be substituted as indicated. And then touching up on pregnancy-related harm. Again, valproic acid and Depakote is highly teratogenic, especially when taken during the first trimester. The risk for major congenital malformations is 4 times higher than with any other AED. Your neural tube defects, such as spina bifida, are the greatest concern. The risk is 1 in 20 among women who are taking Depakote versus 1 in 1,000 who use uh, another medication in the general population. In addition to neural tube defects, valproic acid can cause 5 other major congenital malformations, including an atrial septal defect, a cleft palate, hypospadias, polydactyl, and a craniosynostosis. So, exposure to valproic acid in utero can impair cognitive function. Children who are exposed to valproic acid had IQ scores that were significantly lower than those of children who are exposed to other AEDs. These deficits persist for at least 4.5 years and possibly longer. Valproic acid is a classified FDA pregnancy risk category D and should be avoided by women of childbearing potential. Unless it is the only available AED that will work, women who must use the drug should use an effective form of contraception and should take folic acid supplements to help protect against neural tube damage in case pregnancy does occur. So here is an excellent spot to hit pause so you can see a patient-centered care across the lifespan on anti-epileptic drugs. Hyperammonemia. Combining valproic acid with a topiramate poses a risk for hyperammonemia, which is an excess of ammonia in the blood, which may occur with or without encephalopathy. Symptoms include vomiting, lethargy, altered levels of consciousness, and altered cognitive function. If these symptoms start to develop, a hyperammonemia-anemic encephalopathy should be suspected and blood ammonia levels should be measured. As a rule, symptoms abate after the removal of either drug. Other adverse effects. Depakote may cause a rash, weight gain, hair loss, tremors, and blood dyscrasias, which is a leukopenia, thrombocytopenia, or red blood cell aplasia. Significant CNS effects are considered uncommon. Drug interactions. Valproic acid decreases the rate at which phenobarbital is metabolized. Blood levels of phenobarbital may raise by up to 40%. And significant CNS depression when the combined is used, levels of phenobarbital should be monitored, and if they raise too high, the phenobarbital dosage should be reduced. Valproic acid can also displace dilantin from its binding sites on the plasma proteins. The resultant increase of free dilantin may lead to toxicity. So again, your dilantin levels and clinical status ought to be monitored. Topiramate was already discussed in regard to the hyperammonemia. And finally, carbapenem. There are 2 carbapenem antibiotics. Both the meropenem and imipenem, or cilastatin, can reduce plasma levels of valproic acid. Breakthrough seizures have occurred. So it's important to note that increasing the dosage of valproic acid may still be insufficient to overcome this effect. Accordingly, meropenem and imipenem with cilastatin should be avoided in patients who take valproic acid. Ethosuximide, its therapeutic use. Ethosuximide, also known as Serontin, is the drug of choice when a patient comes in with absence seizures, which is the only indication it has. Absence seizures are eliminated in 60% of patients and in newly diagnosed patients. Practical control is achieved in 80 to 90% of individuals who take this medicine. So how does it work? Your ethosuximide suppresses neurons in the thalamus that are responsible for generating absence seizures. The specific mechanism is the inhibition of low threshold calcium currents, also known as T currents. Ethosuximide does not block sodium channels, and it does not enhance GABA-mediated neuronal inhibition. So, its pharmacokinetics. Ethosuximide is well absorbed after oral administration. Therapeutic plasma levels range between 40 and 100 micrograms per milliliter. The drug is eliminated by the combination of both hepatic and renal excretion. Its half-life is 60 hours in adults and about 30 hours in children. The medication does not induce drug metabolizing enzymes. It does, however, have adverse effects. Ethosuximide is generally devoid of significant adverse effects and interactions. However, during initial treatment, it can cause drowsiness, dizziness, and lethargy. They, however, start to diminish with continued use. Nausea and vomiting may also occur and can be reduced by administering a drug with medication, or food rather. Rare but serious reactions do include, which are systemic lupus erythematosus, leukopenia, aplastic anemia, and Stevens-Johnson syndrome. So, dosage considerations. Ethosuximide has a long half-life. This allows dosing to be done just once a day. However, dosing twice a day is considered better tolerated by most patients. Because absence seizures occur many times throughout the day, monitoring the clinical responses rather than plasma drug level is the preferred method for dosage determination. Dosage should be increased until seizures have been controlled or until adverse effects have become too great. Which brings us to phenobarbital. Phenobarbital is one of our oldest AEDs. It is effective and inexpensive, and it can be administered just once a day. Unfortunately, certain side effects, including lethargy, depression, and learning impairment, can be significant. Although phenobarbital was used widely in the past, it has largely been replaced by newer drugs that are equally effective but better tolerated. Phenobarbital belongs to the barbiturate family. In contrast to most other barbiturates, however, which produce a generalized depression of the CNS, phenobarbital is able to suppress seizures at doses that produce only a moderate disruption of CNS function. Because it can reduce seizures without causing sedation, phenobarbital is classified as an anticonvulsant barbiturate. The basic pharmacology of other barbiturates is discussed in Chapter 27. Discussion here is strictly limited on phenobarbital for its seizure use. The mechanisms of antiseizure action. Phenobarbital suppresses seizures by potentiating the effects of GABA. Specifically, the drug binds to GABA receptors, causing the receptors to respond more intensely to GABA itself. Phenobarbital is administered orally, and absorption is complete. Elimination occurs through the hepatic metabolism and renal excretion. Phenobarbital has a long half-life, about 4 days. As a result, once daily dosing is adequate for most patients. In addition to permitting once daily dosing, the long half-life has another consequence. 2 to 3 weeks is required for plasma levels to reach a plateau. Again, recall that the absence of a loading dose, an interval equivalent to 4 half-lives, is required to reach plateau. So its therapeutic use. In epilepsy, phenobarbital is effective against partial seizures and generalized tonic-clonic seizures, but not in absence seizures. IV phenobarbital can be used for generalized convulsive SE, but other anti-seizure drugs are preferred. Sedation and the induction of sleep. Like other barbiturates, phenobarbital can be used for sedation and to promote sleep at night. These applications will be discussed further in Chapter 27. Its adverse effects. Its neuropsychological effects. Drowsiness is the most common CNS effect. During the initial phase of therapy, sedation develops in practically all patients with continued treatment. Tolerance to sedation starts to develop. Some children and older patients experience a paradoxical response. Instead of becoming sedated, they may become irritable and hyperactive. Cognitive deficits may occur in children. Depression may occur in older adults, and the older adults may also experience agitation and confusion. Physical dependence. Like any other barbiturate, phenobarbital can cause a physical dependence. However, at the doses employed to treat epilepsy, significant dependence is considered unlikely. Exacerbation of intermittent porphyria. Phenobarbital and other barbiturates can increase the risk for acute intermittent porphyria. Accordingly, barbiturates are absolutely contraindicated for patients with a history of this disorder. Use during pregnancy. The use of phenobarbital during pregnancy poses a significant risk for major fetal malformations. Women who take phenobarbital during pregnancy or become pregnant while taking the drug should be informed of the potential risk to the fetus. Similar to dilantin, phenobarbital can decrease synthesis of vitamin K-dependent clotting factors and can thereby cause bleeding tendencies in newborns. The risk for neonatal bleeding can be decreased by administering vitamin K to the mother for 1 month before delivery and during delivery, and to the infant immediately after the delivery. Other adverse effects. Again, similar to dilantin, phenobarbital can interfere with the metabolism of vitamin D and K. Disruption of vitamin D metabolism can cause rickets and osteomalacia. Toxicity. When taken in moderately excessive doses, phenobarbital causes nystagmus and ataxia. Severe overdose produces generalized CNS depression, and death results from depression of respiration. Barbiturate toxicity and its treatment will be discussed again in further detail in Chapter 27. Its drug interactions. Induction of drug metabolizing enzymes. Phenobarbital induces hepatic drug metabolizing enzymes and can thereby accelerate the metabolism of other medications, causing a loss of its therapeutic effects. This is of particular concern, especially with oral contraceptives and Coumadin. CNS depressants. Being a CNS depressant itself, phenobarbital can intensify CNS depression caused by other drugs, including alcohol, benzodiazepines, and opioids. Severe respiratory depression and coma can result. Patients should be warned against combining phenobarbital with other drugs that also have CNS depressant actions. Valproic acid. Valproic acid is an AED that has been used in combination with phenobarbital. By comparing with phenobarbital for drug metabolizing enzymes, valproic acid can increase plasma levels of phenobarbital by approximately 40%. Therefore, when this combination is used, the dosage of phenobarbital must be reduced. Drug withdrawal. When phenobarbital is withdrawn, doses should be reduced gradually because an abrupt withdrawal can precipitate SE. Patients should be warned of this danger and instructed not to discontinue phenobarbital too quickly. Dosage considerations. Phenobarbital has a long half-life. Several weeks are required for drug levels to reach a plateau. If plateau must be reached sooner, a loading dose scheduled should be employed. So, an example of this, doses that are twice normal can be given for 4 days. Alternatively, a dose of 10 to 20 milligrams per kilogram can be administered and repeated in 20 minutes as needed. The administration rate should not exceed 60 milligrams per minute. Unfortunately, these large doses are likely to produce a substantial CNS depression. Which brings us to primidone. Primidone, also known as misoline, is an active against all major seizure disorders, except absence seizures. The drug is nearly identical to the structure of phenobarbital, As a result, the pharmacology of both agents are very similar. So, primidone is readily absorbed after an oral dosing. In the liver, much of the drug undergoes the conversion of two active metabolites, phenobarbital and phenylethylmalonamide. Seizure control is produced by primidone itself and by its metabolites. Therapeutic plasma level ranges from 5 to 12 micrograms per ml. Any levels above 15 micrograms is considered toxic. Its therapeutic use. Primidone is effective again against tonic-clonic, simple partial, and complex partial seizures. The drug is not active against absence seizures. As a rule, primidone is employed in a combination with another AED, usually dilantin or carbamazepine. Primidone is never taken together with a phenobarbital because phenobarbital is an active metabolite of primidone, so concurrent use would be irrational. Its adverse effects. Sedation, ataxia, and dizziness are common during initial treatment, but diminish with continued drug use. Like phenobarbital, primidone can cause confusion in older adults and a paradoxical hyperexcitability in children. A sense of acute intoxication can occur shortly after dosing. As with phenobarbital, primidone is absolutely contraindicated for patients with acute intermittent porphyria. Serious adverse reactions, such as acute psychosis, leukopenia, thrombocytopenia, and systemic lupus erythematosus, can occur but are considered rare. Drug interactions. Drug interactions for primidone are similar to those for phenobarbital. Primidone can induce hepatic drug metabolizing enzymes and can thereby reduce the effects of oral contraceptives, Coumadin, and other medications. In addition, primidone can intensify responses to other CNS depressants. So, now we can talk about some newer antiepileptic drugs. The group of newer AEDs has about 15 members, although most newer AEDs have not been compared directly with the traditional AEDs, or with each other for that matter. All of these drugs appear equally effective. So, do the newer AEDs have properties that make them appealing? Certainly. As a group, they are better tolerated than the traditional AEDs and may pose a smaller risk to the developing fetus. Furthermore, only one, oxcarbamazepine, induces drug metabolizing enzymes to a significant degree, and therefore interaction with other drugs, including other AEDs, are relatively minor. The subject of approved indications for the newer AEDs requires comment, however. When these drugs were first introduced, the FDA-approved indications were limited to adjunctive therapy of certain seizure disorders. None of these drugs was approved for monotherapy because clinical trials were limited to patients who were refractory to traditional AEDs. When the trials were conducted, rather than switching patients from a traditional AED to the experimental AED, the experimental AED was simply added to the existing regimen. Therefore, when the trials were completed, all we knew for sure was that the new AED was effective when used together with an older AED. We had no data on the use of newer AEDs alone. So, as a result, the FDA had no option but to approve the new drug for adjunctive therapy. Since being released, several of the newer AEDs have received FDA approval for monotherapy. To help the prescriber be more comfortable with the newer AEDs, two organizations, the American Academy of Neurology and the American Epilepsy Society, convened a panel to evaluate the efficacy and tolerability of these medications. For some of the newer AEDs, both panels recommended use not yet approved by the FDA. These recommendations, along with FDA approved indications, will be discussed here. So, we'll start with the first one, the oxcarbazepine, also known as Oxtellar. or trileptal, is a derivative of carbamazepine and is approved for the adjunctive therapy of partial seizures in both adults and children. Antiseizure effects result from the blockade of voltage-sensitive sodium column channels in neuronal membranes, an action that stabilizes the hyperexcitability neurons and thereby suppresses seizure spread. The drug does not affect neuronal GABA receptors. Its pharmacokinetics. Oxcarbazepine is well tolerated and absorbed both in the presence and absence of food. In the liver, the drug undergoes a rapid conversion to a 10-monohydroxy metabolite, its active form. The 10-monohydroxy metabolite, also known as MHD, has a half-life of 9 hours and undergoes its excretion in the urine. It does, however, come with adverse effects. The most common are dizziness, drowsiness, double vision, nystagmus, headache, nausea, vomiting, and ataxia. Patients should avoid driving and other hazardous activities unless the degree of drowsiness is considered low. Significant hyponatremia, which is a sodium level of 125 or below, develops in about 2.5% of patients. Signs include nausea, drowsiness, headache, and confusion. If oxcarbazepine is combined with other drugs that can decrease your sodium levels, especially your diuretics, monitoring of sodium levels may be necessary. Similar to carbamazepine, oxcarbazepine can cause serious skin reactions, including Stevens-Johnson syndrome and TEN. There is a 30% cross-sensitivity among patients with hypersensitivity to carbamazepine. Accordingly, patients with a history of severe reactions to either drug should probably not use the other. Oxcarbazepine has not caused any severe hematologic abnormalities, which were seen with carbamazepine. Accordingly, routine monitoring of blood counts is not required. Oxcarbazepine has been associated with serious multi-organ hypersensitivity reactions. Although manifestations are considered varied, patients typically present with a fever and rash associated with one or more of the following: lymphadenopathy, hematologic abnormalities, pruritus, hepatitis, nephritis, hepatorenal syndrome, oliguria, arthralgia, or asthenia. If this reaction is suspected, oxcarbazepine should be discontinued. Other drug interactions. Oxcarbazepine induces some drug metabolizing enzymes and inhibits others. It does not induce enzymes that metabolize other AEDs. However, it does induce enzymes that metabolize oral contraceptives and can therefore render them less effective. Accordingly, women should employ an alternative birth control method. Oxcarbazepine inhibits the enzymes that metabolize dilantin and can thereby raise dilantin levels. Toxicity, therefore, can result. Dilantin levels should be monitored and dosage adjusted accordingly. Drugs that induce drug metabolizing enzymes, including dilantin, phenobarbital, and carbamazepine, can reduce levels of MHD and the active form of oxcarbazepine. Accordingly, dosage of oxcarbazepine may need to be increased. Alcohol can intensify CNS depression caused by oxcarbazepine, so it should be avoided. And as noted, oxcarbazepine should be used with caution in patients who take a diuretic and other drugs that can lower sodium levels. Which brings us to our next medication, lamotrigine. Lamotrigine, also known as Lamictal, has a broad spectrum of anti-seizure activity. The drug is FDA approved for the adjunctive therapy of partial seizures in adults and children who are older than 2 years of age. Adjunctive therapy of generalized seizures associated with a Lennox-Gastaut syndrome in adults and children older than 2 years of age adjunctive therapy of primary generalized tonic-clonic seizures, again in adults and children older than 2, and finally, monotherapy of partial seizures in patients at least 13 years of age who are converting from another AED. In addition, both the AAN and the AES guideline recommend using Lamictal for absence seizures. Lamictal is also FDA approved for long-term maintenance therapy of bipolar disorder. Investigational uses include a myoclonic absence and a temporal lobe seizure. Its mechanism of action: benefits derive mainly from blocking sodium channels and partly from blocking calcium channels. Both of these actions decrease the release of glutamate, an excitatory neurotransmitter. Its pharmacokinetics: its administration is oral and absorption is nearly complete, both in the presence and absence of food. Blood levels peak in 1.5 to 5 hours after dosing and start to decline with a half-life of 24 hours. The drug undergoes hepatic metabolism, followed by renal excretion. Drug interactions: the half-life is dramatically affected by drugs that induce or inhibit hepatic drug metabolizing enzymes. Enzyme inducers, such as your carbamazepine, dilantin, and phenobarbital, decrease the half-life of Lamictal to about 10 hours, whereas Depakote increases the half-life to almost 60 hours. Lamictal itself is not an inducer or inhibitor of drug metabolism. Estrogens can lower Lamictal levels, whereas Lamictal may lower progestin levels. This can create a unique concern for the provider caring for a woman of childbearing age who wants to take oral contraceptives. Its adverse effects: common side effects, include dizziness, diplopia, blurred vision, nausea, vomiting, and headaches. Of much greater concern, patients may develop life-threatening rashes. Again, your Stevens-Johnson syndrome and your TEN. Death even has occurred. The incidence of severe rash is about 0.8% in patients that are younger than 16 years of age and 0.3% in the adult population. Concurrent use of valproic acid increases this risk. If a rash starts to develop, Lamictal should be withdrawn immediately. So that brings us to our black box warning on Lamictal. Again, Lamictal can cause serious skin reactions, which include Stevens-Johnson syndrome and TEN, to the point where fatalities have been reported. So, very rarely, patients experience aseptic meningitis, which is the inflammation of the meninges in the absence of a bacterial infection. Patients who develop symptoms of meningitis, your headache, fever, stiff neck, nausea, vomiting, rash, sensitivity to light, should undergo immediate evaluation to determine the cause. Treatable causes should be managed as indicated. If no clear cause other than Lamictal is identified, discontinuation of Lamictal should be considered. Risk for suicide may be greater than with most other AEDs, so screening your patient for suicidal ideation before starting treatment and to monitor for suicidal ideation during the treatment course is indicated. Which brings us to gabapentin. Gabapentin, also known as Neurontin, has a broad spectrum of anti-seizure activity. However, its only FDA-approved use in epilepsy is adjunctive therapy for partial seizures, with or without secondary generalization. Both the AAN and AES guidelines also recommend the drug for monotherapy of partial seizures. Gabapentin also has been approved for treating post-herpetic neuralgias. Interestingly, more than 80% of prescriptions are written for off-label use, including the relief of neuropathic pain, prophylaxis of migraines, treatment of fibromyalgia, and the relief of postmenopausal hot flashes. However, benefits in these disorders are considered modest at best. Gabapentin does not appear effective in bipolar disorder. Two forms of gabapentin are not currently indicated for the management of epilepsy: and therefore should not be confused with the form of gabapentin known as Neurontin. These are gabapentin ER, also known as Grelise, which is approved for management of post-herpetic neuralgia, and gabapentin enacarbil, or Horizont, a prodrug form of gabapentin approved for the treatment of moderate to severe restless leg syndrome. Owing to the differences in the pharmacokinetics, these forms of gabapentin are not interchangeable with each other or with Neurontin. So, how does it work? The mechanism of action. Gabapentin's precise mechanism of action is still considered unknown. This drug is an analog of GABA, but it does not directly affect GABA receptors. Rather, it may enhance GABA release, thereby increasing GABA-mediated inhibition of neuronal firing. Its pharmacokinetics. Gabapentin is rapidly absorbed after oral dosing and reaches peak plasma levels in about 2 to 3 hours. Absorption is not affected by food. However, as the dosage starts to get larger, the percentage absorbed gets smaller. Because at high doses, the intestinal transport system for uptake of these drugs becomes saturated. Gabapentin is not metabolized and is excreted intact in the urine. Its half-life is only 5 to 7 hours. Drug interactions. Unlike most other AEDs, gabapentin is devoid of significant interactions. It doesn't induce or inhibit drug metabolizing enzymes, and it doesn't affect the metabolism of other drugs. As a result, gabapentin is well suited for combined use with other AEDs. It does come with adverse reactions. Gabapentin is generally well tolerated. The most common side effect is somnolence, dizziness, ataxia, fatigue, nystagmus, and peripheral edema. These are generally mild to moderate and often diminish with continued drug use. Patients should avoid driving or hazardous activities until they are confident they are no longer impaired. Which brings us to pregabalin, also known as Lyrica, which is an analog of GABA. It is much like gabapentin. Like gabapentin, Lyrica is used for seizures and neuropathic pain. In addition, pregabalin is approved for fibromyalgia. Lyrica has very few interactions with other drugs, but adverse effects are common, especially dizziness and sleepiness. In contrast to most other anti-seizure agents, Lyrica is regulated under the Controlled Substance Act. Its therapeutic use. Lyrica has 4 approved indications: neuropathic pain associated with diabetic neuropathy, postherpetic neuralgia, adjunctive therapy of partial seizures, and finally fibromyalgia. So how does it work? Although again, the precise mechanism of action hasn't been fully established, we do know that Lyrica combined with calcium channels on nerve terminals and can thereby inhibit calcium influx, which in turn can inhibit release of several neurotransmitters, which include glutamate, norepinephrine, and substance P. Reduced transmitters release may underlie seizure control and relief of neuropathic pain. Although Lyrica is an analog of GABA, the drug does not bind with GABA receptors or with benzodiazepine receptors, and therefore does not work by mimicking or enhancing the inhibitory actions of GABA. So, its pharmacokinetics. Lyrica is well absorbed after an oral dose. Its plasma levels peak in 1.5 hours, and food reduces the rate of absorption, but not to the extent. Its oral bioavailability is 90% or greater. Lyrica does not bind with plasma proteins, but does cross the blood-brain barrier and a placental barrier. Elimination is renal, 98% unchanged drug. Metabolism is considered negligible, and the half-life is about 6.3 hours. It does have adverse effects, like any other medication. Lyrica can cause a variety of adverse effects. The most common are dizziness and somnolence, which often persist as long as the drug is being taken. Blurry vision may develop during early therapy but starts to resolve with continued drug use. About 8% of patients may experience a significant weight gain. Other adverse effects include difficulty thinking, headaches, peripheral edema, and dry mouth. Post-marketing reports indicate a risk for hypersensitivity reactions, including a life-threatening angioedema, characterized by swelling of the face, tongue, lip, gums, throat, and larynx. Patients should discontinue Lyrica immediately at the first sign of angioedema and any other hypersensitivity reactions, which would include blisters, hives, rashes, dyspnea, and wheezing. In clinical trials, 3 patients developed rhabdomyolysis. However, it's not clear that Lyrica was the cause. Nonetheless, patients should be instructed to report signs of muscle injury. If rhabdomyolysis is diagnosed or even suspected, Lyrica should be withdrawn. Abuse potential and physical dependence. In clinical trials, 4 to 12% of patients reported euphoria as a side effect. When given to recreational users of sedative hypnotic drugs, Lyrica produced subjective effects perceived as similar to those of diazepam or Valium. On the basis of these data, the Drug Enforcement Agency has classified Lyrica under a Schedule 5 of the Controlled Substance Act. Abrupt discontinuation can cause insomnia, nausea, headache, diarrhea, and other symptoms that suggest a physical dependence. To avoid withdrawal symptoms, Lyrica should be discontinued slowly over the course of at least 1 week or more. Possible reproductive toxicity. At this time, Lyrica is classified in the FDA pregnancy risk group as a Category C. During animal study testing, it showed that there is a risk to fetal harm, but no controlled studies in women have been done. The reason for this designation is that data on human reproduction are lacking. When given a pregnant female rat or rabbits, Lyrica caused fetal growth delay, fetal death, structural abnormalities in the skeletal and visceral malformations, and impaired function of the nervous system and reproductive system. Given this choice of a different AED is recommended for a patient that is pregnant. When given to a male rat before and during mating with untreated females, Lyrica decreased sperm count and motility, decreased fertility, reduced fetal weight, and caused fetal abnormalities. So, men using the drug should be informed about the possibility of decreased fertility and male-mediated teratogenicity. The use of condoms is recommended for men taking pregabalin who has sex with women who may become pregnant. Use in breastfeeding. We do not know for certainty whether certain pregabalin or Lyrica is excreted in breast milk. Until additional data is available, it is best for patients to either stop nursing or stop taking Lyrica, unless it is determined that the benefit of breastfeeding outweighs the risk of pregabalin exposure in the infant. Drug interactions. Your alcohol, opioids, benzodiazepines, and any other CNS depressant may intensify the depressant effects of Lyrica. Accordingly, such combinations should be avoided. Extensive studies have failed to show pharmacokinetic interactions with other drugs. Pregabalin does not inhibit cytochrome P450 isoenzymes. Whether it can induce these isoenzymes is still unknown. Lyrica does not interact with other oral contraceptives and does not alter the kinetics of any anti-seizure drug studied. Which brings us to our next medication. Levetiracetam, also known as Keppra, is a unique agent that is chemically and pharmacologically different from all other AEDs. So, how Keppra acts is unknown. However, we know that it does not bind to receptors for GABA or any other known neurotransmitter. In the US, the drug is approved for adjunctive therapy of myoclonic seizures in adults and adolescents, 12 years and older, It's also given for partial onset seizures in adults and children 4 years and older, and is primarily generalized for tonic-clonic seizures in adults and children 6 years and older. Unlabeled use includes migraine, bipolar disorder, and new-onset pediatric epilepsy. In Europe, the drug is approved for monotherapy of partial seizures, for which it is highly effective. Its pharmacokinetics. After oral dosing, Keppra undergoes rapid and complete absorption both in the presence and absence of food. Metabolism is minimal and not mediated by hepatic cytochrome P450 isoenzymes. Keppra is excreted in the urine by about 66% unchanged. Its adverse effects. Adverse effects are generally mild to moderate. The most common are drowsiness and asthenia, a lack of strength or weakness. Your neuropsychiatric symptoms, agitation, anxiety, depression, psychosis, hallucinations, depersonalization, occur in less than 1% of patients. In contrast to other AEDs, Keppra does not impair speech, concentration, or other cognitive functions. Unlike most other AEDs, Keppra does not interact with other drugs. It does not alter plasma concentrations of oral contraceptives, Coumadin, digoxin, or other AEDs. These benefits are primarily attributable to the fact that Keppra is not metabolized by P450 isoenzymes. Which brings us to topiramate. Topiramate, or Topamax, is another broad-spectrum anti-seizure agent. The drug is FDA approved for, again, adjunctive treatment of adults and children 2 years and older with partial seizures, primarily generalized tonic-clonic seizures and seizures associated with the Lennox-Gastaut syndrome. It's also given for monotherapy of adults and children 10 years and older with partial seizures or primarily generalized tonic-clonic seizures, and the prophylaxis of migraines in adults, which is discussed in Chapter 23. Seizure reduction occurs by 4 mechanisms: the potentiation of GABA-mediated inhibition, the blockade of voltage-dependent sodium channels, blockade of receptors for glutamate and excitatory neurotransmitter, and finally the inhibition of carbonic anhydrase. Unlabeled use includes bipolar disorder, cluster headaches, neuropathic pain, infantile spasms, essential tremor, binge eating disorders, bulimia nerviosa, and weight loss. Studies also show a promise for management of both alcohol and cocaine dependence. So, it's pharmacokinetics. With oral administration, absorption is rapid and not affected by food. Plasma levels peak in about 2 hours after dosing, and most of the drug is eliminated unchanged in the urine. Its adverse effects. Although topiramate is generally well tolerated, it can cause multiple adverse effects. Common effects include somnolence, dizziness, ataxia, nervousness, diplopia, nausea, anorexia, and weight loss. Cognitive effects, including confusion, memory difficulties, altered thinking, reduced concentration, difficulty finding words, can occur, but the incidence rate is considered low at recommended dosages. Kidney stones and paresthesias occur rarely. Topiramate can cause metabolic acidosis. The drug inhibits carbonic anhydrase and therefore increases renal excretion of bicarbonate, which causes the plasma pH to fall. Hyperventilation is the most characteristic symptom. Mild to moderate metabolic acidosis develops in about 30% of individuals, but severe acidosis is considered rare. Your risk factors include renal disease, severe respiratory disorders, diarrhea, and a ketogenic diet. Prolonged metabolism acidosis can lead to kidney stones, fractures, and growth delay. Serum bicarbonate should be measured at baseline and periodically thereafter. You want to advise patients to inform the prescriber if they experience of hyperventilation and other symptoms do occur. If metabolic acidosis is diagnosed, topiramate should be given in reduced dosage or discontinued. Topiramate can cause hypohidrosis, which is reduced sweating, thereby posing a risk for hyperthermia. Significant hyperthermia is usually associated with vigorous activity and an elevated environmental temperature. There have been case reports of angle closure glaucoma. Left untreated, this rapidly leads to blindness. Patients should be informed about symptoms of glaucoma and be instructed to seek immediate attention if these start to develop. Fortunately, topiramate-induced glaucoma is considered rare. Topiramate is classified in FDA pregnancy risk category D and therefore should only be used if the benefits of maternal seizure control are deemed to outweigh the risk to the fetus. Women using topiramate should use an effective form of birth control or should switch to a safer anti-seizure drug if pregnancy is intended. Risk for suicide may be greater than with most other AEDs, so screening patients for suicidal ideation before starting treatment and monitoring it during treatment is required. Other drug interactions. Dilantin and carbamazepine can decrease levels of topiramate by about 45%, so topiramate may increase levels of dilantin. Which brings us to our next medication, tiagabine. Tiagabine, also known as Gabatril, is FDA approved only for adjunctive therapy of partial seizures in patients at least 12 years old. The drug reuptake of GABA by neurons and glia. As a result, the inhibitory influence of GABA is intensified and seizures are suppressed. Off-label use includes the management of generalized anxiety disorders, multiple sclerosis, neuropathic pain, post-traumatic stress disorder, psychosis, and spasticity. Recent studies show promise for use of tiagabine in migraine prophylaxis as well as management of bipolar disorder and insomnia. However, owing to the risk for seizures, such off-label use is discouraged. So what are the pharmacokinetics? Tiagabine has uncontrolled kinetics, so the administration is oral, absorption is rapid and nearly complete, and food seems to reduce the rate of absorption, but not to the extent. Plasma levels peak in about 45 minutes after dosing. In the blood, tiagabine is highly bound to the plasma proteins, almost 96%. Elimination by hepatic metabolism, followed by the excretion in the bile and, to a lesser extent, in urine. The serum half-life is 7 to 9 hours. So, its adverse effects. Tiagabine is generally well tolerated. Common adverse effects are dizziness, somnolence, asthenia, nausea, nervousness, and tremors. Like most other AEDs, tiagabine can cause dose-related cognitive effects. Again, confusion, abnormal thinking, and trouble concentrating. The medication has caused seizures in some patients, but only in those who are using the drug off-label. A few patients also have developed SE, which can be life-threatening. In most cases, seizures occurred sooner after starting tiagabine or after increasing the dosage. Because of seizure risk, off-label use for tiagabine should be avoided. So why are people without epilepsy at risk? Possibly because they are not taking AEDs. Again, remember that tiagabine is approved only for adjunctive use with another AED. It may be that the drug protects against tiagabine-induced seizures because people without epilepsy taking tiagabine by itself, they are no longer protected from seizure development. So, its drug interactions. Tiagavine does not alter the metabolism or serum concentration of other AEDs. However, levels of tiagavine can be decreased by dilantin, phenobarbital, and carbamazepine, all of which induce drug metabolizing enzymes. Which brings us to our next medication. Sonacimide, or Sonogran, is approved only for the adjunctive therapy of partial seizures in adults. Again, the drug belongs to the same chemical family as sulfonamide antibiotics, but it lacks antimicrobial activity. In animal models, Sonogran suppresses focal seizure activity and spread. The underlying mechanism appears to be the blockade of neuronal sodium channels and calcium channels. This drug is sometimes used off-label for the management of bipolar disorder, migraine prophylaxis, and Parkinson's disease. Its pharmacokinetics. Sonogran undergoes rapid absorption from the GI tract. Bioavailability is nearly 100% in both the presence and absence of food. In the blood, Sonogran is extensively bound to erythrocytes. As a result, its concentration in erythrocytes is 8 times higher than in plasma. Sonogran is metabolized in the liver by the 3A4 isoenzymes of cytochrome P450. So again, your CYP 3A4. Excretion occurs in the urine. 30% is excreted unchanged, with the remainder in the form of metabolites. The plasma half-life is 63%. It does come with adverse effects. The most common are drowsiness, dizziness, anorexia, headache, and nausea. Metabolic acidosis is also common. Like most other AEDs, Sonogran can impair speech, concentration, and cognitive progress and processes. Because the drug can reduce alertness and impair cognition, patients should avoid driving and other hazardous activities until they know how the drug affects them personally. Sonogran can have severe psychiatric effects. While there were clinical trials, 2.2% of patients either discontinued treatment or were hospitalized because of severe depression and attempted suicides in 1.1% of individuals. Like all other sulfonamides, Sonogran is trigger hypersensitivity reactions, include some that are potentially fatal. Accordingly, Sonogran is contraindicated for patients with a history of a sulfonamide hypersensitivity. Patients who develop a rash should be followed closely because rash can evolve into a more serious event. If hypersensitivity starts to develop, sonacimide should be withdrawn immediately. Fortunately, serious reactions and fatalities are considered rare. Sogran has adverse effects on the kidneys. In clinical trials, about 4% of patients developed nephrolithiasis. The risk can be reduced by drinking 6 to 8 glasses of water a day. Patients should be informed about the signs of kidney stones, sudden back pain, abdominal pain, painful urination, bloody or dark urine, and instructed to report them immediately. In addition to nephrolithiasis, Sonogran can impair glomerular filtration. Because of its effects on the kidney, sonacimide should be withdrawn or used with caution in patients who do have a history of kidney disease. Similar to topiramate, Sonogran inhibits carbonic anhydrase and can therefore cause metabolic acidosis. The condition develops in about 90% of children and 43% of adults. And those usually occur early on in treatment. The risk is increased by renal disease, respiratory disease, diarrhea, and followed by a ketogenic diet. Metabolic acidosis can delay growth in children, and over time can lead to kidney stones and fractures in all patients. Advise patients to report a hyperventilation and other signs of metabolic acidosis. Determine plasma bicarbonate at baseline and periodically thereafter. If metabolic acidosis is diagnosed, sonogram should be discontinued or given in a reduced dosage. Rarely, sonogram causes hypohidrosis and hyperthermia. Pediatric patients may be at special risk. In warm weather, hypohidrosis may lead to a heat stroke and subsequent hospitalizations. Patients should be monitored closely for reduced sweating and increased body temperature. So, drug and food interactions. Because sonogram can be affected by agents that induce or inhibit the CYP3A4, inducers of CYP3A4 need to be monitored, including your St. John's wort and several other AEDs, your phenytoin or dilantin, phenobarbital, carbamazepine. They all can accelerate the metabolism of sonogram and can therefore reduce the drug's half-life. Conversely, inhibitors of your CYP3A4, such as your grapefruit juice, your azole antifungal agents, and several protease inhibitors can slow the metabolism of sonogram and therefore prolong and intensify its effects. Which brings us to felbamate. Felbamate, also known as felbatol, is an effective AED with a broad spectrum of antiseizure activity. Unfortunately, the drug has potential fatal adverse effects, which include aplastic anemia and liver failure. Accordingly, use is restricted to patients with severe epilepsy refractory to all other treatment. So how does it work? Felbamate increases the seizure threshold and suppresses seizure spread. The underlying mechanism is unknown. Unlike some AEDs, such as your phenobarbitals and benzodiazepines, felbamate does not interact with GABA receptors and does not enhance the inhibitory actions of GABA. Felbamate is well absorbed after oral dosing, both in the presence and absence of food. Plasma levels peak in 1 to 4 hours. The drug readily penetrates to the CNS, although therapeutic plasma levels have not been established. Levels of 20 to 120 micrograms per ml have been measured during the clinical trials. Felbamate is eliminated in the urine, primarily unchanged, and its half-life is anywhere between 14 to 23 hours. So, its therapeutic use. Felbamate has been approved for the adjunctive or monotherapy in adults with partial seizures, and in adjunctive therapy in children with Lennox-Gastaut syndrome. However, because of toxicity, use of the drug is very limited. Again, speaking on its adverse effects, felbamate can cause aplastic anemia and liver damage. Because of the risk for liver failure, felbamate should not be used in patients who have any kind of pre-existing liver condition or dysfunction. In addition, patients taking the drug should be monitored for indications of liver injury. Which brings us to its black box warning. Again, felbamate has been associated with an increased risk for aplastic anemia. Associated fatality rates had been established at 20 to 30%. However, rates up to 70% have been attributed to the use of this drug. So, other adverse effects include anorexia, nausea, and vomiting, and CNS effects include insomnia, somnolence, dizziness, headaches, and diplopia. These occur more frequently when felbamate is combined with other medications. Its drug interactions. Felbamate can alter plasma levels of other AEDs, and vice versa. Felbamate increases levels of dilantin and depakote. Levels of felbamate are increased by depakote and reduced by dilantin and carbamazepine. Increased levels of dilantin and depakote could lead to toxicity, leading to reduced levels of felbamate could lead to therapeutic failure. Therefore, to keep the levels of these drugs within a therapeutic range, their levels need to be monitored and dosages adjusted accordingly. Which brings us to lacosamide, also known as Vimpat. Vimpat is indicated for add-on therapy of partial onset seizures in patients 17 years or older. Its benefits appear to derive from slow inactivation of sodium channels, resulting in the stabilization and hyperexcitability neuronal membranes and subsequent inhibition of repetitive firing. In patients with refractory partial onset seizures, adding Vimpat to the regimen reduced seizure frequency by 50% or more in about 40% of those treated. Compared with other drugs for partial onset seizures, Vimpat has two advantages. First, it has few drug interactions, and secondly, it can be administered IV as well as orally. Vimpat undergoes complete absorption after oral administration, and therefore oral doses produce the same effect as or equivalent effect as an IV dose. Drug levels peak 1 to 4 hours after oral dosing and decline with a half-life of 13 hours. Elimination is done in combination of hepatic metabolism and renal excretion. Its adverse effects. Vimpat is generally well tolerated. The most common adverse effects are dizziness, headaches, diplopia, and nasopharyngitis. Other effects include vomiting, fatigue, incoordination, blurred vision, tremors, somnolence, and cognitive changes, including impaired memory, confusion, and attention disruption. Vimpat can prolong the PR interval, so it should be used with caution in patients who have a cardiac conduction problem and in those taking other drugs that prolong a PR interval. About 1% of patients experience euphoria. As a result, Vimpat is classified as a Schedule V drug under the Controlled Substance Act. Similar to other AEDs, Vimpat carries a small risk for suicidal thoughts or ideations. Drug interactions. Vimpat has few drug interactions. During its clinical trials, it had little effect on plasma levels of other AEDs. However, carbamazepine, fosphenytoin, phenytoin, and phenobarbital may decrease the serum concentration of Vimpat. As noted, Vimpat should be used with caution in patients taking other drugs that, again, can prolong that PR interval, which would include our beta blockers, calcium channel blockers. Which brings us to our next medication, rufinamide. Rufinamide, also known as benzo, again is approved as an add-on therapy for seizures associated with Lennox-Gastaut syndrome, a severe form of childhood epilepsy. Some other AEDs, such as phenytoin or dilantin, and carbamazepine. Rufinamide appears to suppress seizure activity by prolonging the inactive state of neuronal sodium channels. In clinical trials, the drug reduced seizure frequency as well as their severity. Rufinamide is well absorbed after oral dosing, especially in the presence of food. Plasma levels peaked in 4 to 6 hours. Elimination was done via the enzymatic conversion to inactive products, followed by the excretion in the urine. Of note, inactivation does not involve cytochrome P450 isoenzymes. The plasma's half-life was 6 to 10 hours. Its adverse effects differ somewhat between children and adults. In children, the most common adverse effects were somnolence, vomiting, and headaches. However, in adults, the most common effects were dizziness, fatigue, nausea, and somnolence. Rufinamide can reduce the QT interval on an EKG, so it should not be used with patients with a familial short QT syndrome. Like all other AEDs, rufinamide may increase suicidal thoughts and behaviors. Its drug interactions. For other AEDs, your carbamazepine, your phenobarbital, dilantin, and primidone can significantly reduce levels of rufinamide. Because rufinamide is not metabolized by P450 isoenzymes, the induction of cytochrome P450 cannot be the mechanism. One AED Our valproic acid, or Depakote, can increase rufinamide levels by up to 70%. Rufinamide causes a mild induction of CYP3A4 and can thereby reduce levels of ethinyl estradiol and your norethindrone, common components of oral contraceptives. An alternative form of contraception may be required. Because rufinamide shortens the QT interval, the drugs that shorten the interval, such as digoxin, should be used with caution. Which brings us to vigabatrin. Vigabatrin, also known as Sabril, has two indications. It's an add-on therapy of complex partial seizures in adults who are refractory to other drugs, and the monotherapy of infantile spasms in children ages 6 months to 2 years. Vigabatrin is the first drug approved in the US for infantile spasms, a severe seizure disorder that occurs in children during the first year of life. Benefits in adults and children derive from inhibiting GABA transaminase, the enzyme that inactivates GABA in the CNS. By preventing GABA inactivation, vigabatrin increases GABA availability and therefore enhances GABA-mediated inhibition of neuronal activity. Unfortunately, although vigabatrin is effective, it is also dangerous. The drug can cause permanent loss of vision. So its pharmacokinetics. Vigabatrin is administered orally, with or without food. Its plasma levels peak in half an hour to 2 hours, with a bioavailability that is almost 100%. The drug undergoes little or no metabolism and is eliminated primarily by the renal excretion, with a half-life of 7.5 hours. Monitoring plasma drug levels do not help optimize treatment. Which brings us to its adverse effects. Again, we spoke on it a little bit already. Vision loss. Vigabatrin can cause irreversible damage to the retina, usually manifesting as progressive narrowing of the visual field. Severe damage can produce tunnel vision. Some degree of visual field reduction occurs in 30% or more of patients. Damage to the central part of the retina can reduce visual acuity. Some patients experience retinal damage within 2 days to weeks of treatment onset, whereas others may use the drug for months to years before damage starts to occur. Which brings us to that black box warning. Again, vigabatrin can cause permanent loss of peripheral vision. Vision should be tested at baseline, then at 4 weeks and every 3 months thereafter, so long as therapy continues to be in use. To reduce the extent of damage, vision should be tested at baseline and every 3 months. If vision is detected, or if vision loss is detected rather, vigabatrin should be discontinued. Stopping will not, however, reverse that damage that already has occurred, but may limit developing or further damage. Unfortunately, even with periodic testing, some patients will develop severe vision loss. Owing to the risk of vision loss, vigabatrin is available only through a restricted use program, known as the SHARE program. The goal is to monitor for vision damage and discontinue the drug as soon as possible when damage is detected. SHARE requires registration by the prescriber, pharmacist, adult patient, and/or parent guardians of the young patient. In addition, the program requires the adult and pediatric patients to undergo regular vision testing. So, other adverse effects aside from vision loss. In clinical trials, the most common adverse effect in adults who received vigabatrin plus other AEDs included headaches, somnolence, fatigue, dizziness, convulsions, an increase in weight, vision field defects, and depression. Like other AEDs, vigabatrin can promote suicidal thoughts and behaviors. Among children, the most common adverse effect was somnambulism, bronchitis, and otitis media. Its drug interactions. Again, the risk for retinal damage is increased by combining this medication with other drugs that could directly damage the retina. The big one is hydroxychloroquine, or with drugs that promote glaucoma, including your glucocorticoids, your tricyclic antidepressants. Vigabatrin can reduce levels of dilantin by, by the induction of the CYP2C9, the 2C9 isoenzymes of cytochrome P450, and can increase levels of clonazepam by a mechanism, however, that is still unknown at this time. Ezogabine. Ezogabine, or Potiga, is a first-in-class potassium channel opener. The drug is approved for the adjunctive treatment of partial onset seizures. Potiga activates voltage-gated potassium channels in the neuronal membrane and thereby facilitates potassium efflux. As a result, repetitive neuronal firing and related seizure activity are reduced. Unfortunately, Potiga also activates potassium channels in the bladder epithelium and therefore promotes urinary hesitancy or urinary retention, a unique side effect among the other AEDs. Because of its effects on the bladder, Potiga should be used with caution, if at all, in patients with a pre-existing voiding difficulty. The drug can impart a red-orange color to the urine. This effect is harmless and unrelated to the urinary retention. The most common adverse reactions are somnolence, dizziness, fatigue, confusion, vertigo, tremor, incoordination, double vision, memory impairment, and a reduced strength. In addition, Potiga can cause hallucinations and other symptoms of psychosis. There have been no reports of a rash, vision impairment, liver damage, or adverse hematologic effects. Potiga has the potential for abuse and is under the review for possible regulation as a controlled substance. Similar to other AEDs, Potiga may increase the risk for suicidal thoughts and behaviors. In contrast to many AEDs, Potiga has few interactions with other drugs. Which brings us to eslicarbazepine. Eslicarbazepine, also known as Aptiom, is approved for the management of partial seizures. It may be used as either monotherapy or as an adjunct to ongoing therapy. Its mechanism of action appears to be related to the blockade of a sodium channel. The pharmacokinetics. This drug is metabolized to the liver or to its active metabolite on its first pass through metabolism. As a result, bioavailability is as high as 90%. Peak time is in 1 to 4 hours with a half-life of 13 to 20 hours. It is primarily excreted through the urine. Its adverse effects. Most of eslicarbazepine adverse effects are related to the actions on CNS, which include dizziness and sedation. More than 10% have developed headaches and diplopia. It does, however, have drug interactions. Because it is a CYP2C19 inhibitor and a CYP3A4 inducer. This mechanism behind many of the interactions with this drug. When prescribed, for instance, with dilantin, eslicarbazepine can increase dilantin levels, and dilantin can decrease its levels. Carbamazepine and phenobarbital can also decrease levels of eslicarbazepine. Other significant interactions may occur with statins, hormonal contraceptives, and Coumadin. Eslicarbazepine can lower levels of all of these drugs. Dosage adjustments may be required, and alternative forms of birth control may be needed to be considered. Which brings us to the Perampanel, its actions and uses. Perampanel is approved for the adjunctive therapy for treatment of both tonic-clonic seizures and partial seizures. Its anti-epileptic effects are the result of an AMPA glutamate antagonist. When taken on an empty stomach, the absorption is rapid and its peak time is half an hour to 2.5 hours. Approximately 95% of perampanel is protein-bound. Multiple isoenzymes are involved in the metabolism of perampanel, including CYP3A4 and 5, CYP1A2, and CYP2B6. Excretion is primarily via the feces, with about 20% in the urine. Adverse effects: atypical anger and aggression have occurred in some patients taking this medication. This may occur in as many as 20% of the patients who are taking this drug. Its black box warning of perampanel, therefore, because it has been associated with serious psychiatric reactions, these include anger, aggression, hostility, violence, and even homicidal ideation. Other than hostility, the most common adverse effects are dizziness, drowsiness, fatigue, and headache. Nausea, vomiting, abdominal discomfort, and weight gain may also occur. Its drug interactions, therefore. Perampanel can decrease the effectiveness of hormonal contraceptives, particularly progestins. It can enhance the effects of CNS depressants, therefore increasing the risk related to the sedation and of significant respiratory drive. Dilantin, carbamazepine, and oxcarbazepine can decrease perampanel levels by 50% or more through the hepatic enzyme induction. Care must be undertaken to adjust for this when making adjustments in therapy. Maternal and fetal or even infantile bleeding risks are also a concern. Phenobarbital, dilantin, carbamazepine, and primidone reduce levels of vitamin K-dependent clotting factors by inducing hepatic enzymes, increasing the risk for bleeding. To reduce the risk, some sources, include product labeling, recommend that pregnant patients be given a vitamin K before delivering. The most recent guidelines of the AAN and AES, however, concluded that evidence is insufficient to support vitamin K administration in a pregnant patient. They also do not recommend a vitamin K supplementation in the neonates born to these women, beyond the recommended for all newborns. For additional information on that, there is a website listed here. Feel free to hit pause so you can read the PDF. For women of childbearing age who are not pregnant, it is essential to consider interactions of AEDs with oral contraceptives. 8 AEDs decrease the effectiveness of oral contraceptives. Again, your carbamazepine, your eslicarbazepine, lamotrigine, oxcarbazepine, dilantin, phenobarbital, rufinamide, and topiramate. 4 of these, carbamazepine, dilantin, phenobarbital, and topiramate, are also associated with harm to the human fetus. If it is necessary to prescribe any of these medications, it is important to advise the patient of the risks and the need for additional contraceptives if pregnancy is not desired. Its management of generalized convulsive status epilepticus. So, convulsive SE is defined as a continuous series of tonic-clonic seizures that again last at least 20 to 30 minutes. Consciousness is lost during the entire attack. Tachycardia, an elevation of blood pressure, and hyperthermia are typical. Metabolic sequelae include hypoglycemia and acidosis. If SE persists more than 20 minutes, it can cause permanent neurologic injury. So cognitive impairment, memory loss, a worsening of the underlying seizure disorder, and even death. Generalized convulsive SE is a medical emergency that requires immediate treatment. Management of SE is discussed in more detail in Chapter 89. Which brings us to prescribing and monitoring considerations, implications that apply to all anti-epileptic drugs. Again, the goal of treatment is to minimize or eliminate the seizure event. Therefore, allowing the patient to live a normal life or nearly normal life. Baseline data. Before initiating treatment, it is essential to know the type of seizure involved. Again, whether it's an absence, generalized tonic-clonic, what have you, and how often these seizures occur. Administration considerations. The dosage determination. Again, dosages are often highly individualized and difficult to establish. Clinical evaluation of therapeutic and adverse effects is essential to establish a dosage that is both safe and effective. For several AEDs, especially those that are used to treat the tonic-clonic seizures, knowledge of plasma AED levels can facilitate dosage adjustments. Promoting adherence. Again, seizure control requires rigid adherence to the prescriber's regimen. Non-adherence is a major cause of therapeutic failure. So, monitoring plasma AED levels can motivate adherence and facilitate assessment of non-adherence. Ongoing monitoring and interventions. The evaluation of therapeutic effects by teaching the patient and family members to maintain a seizure frequency chart indicating the date, time, and the nature of the seizure event. The prescriber can use this record to evaluate treatment, make dosage adjustments, and alter drug selections. By minimizing the danger from uncontrolled seizures, potentially hazard activities must be restricted until the seizure control is achieved. Also, because seizures may reoccur after they are largely under the control, patients need to carry some form of identification to aid the diagnosis and treatment if a seizure does occur. And then finally, minimizing adverse effects. Again, that's CNS depression. Most AEDs suppress and depress the CNS. Signs of CNS depression, such as sedation, drowsiness, and lethargy, are the most prominent during the initial phase of treatment, and decline with continued drug use. Until this effect starts to decline, patients need to avoid driving and other hazardous activities. Until then, to minimize adverse CNS effects, the use of low initial doses and give the largest portion of the daily dose at bedtime. Withdrawal seizures. Again, abrupt discontinuation of any AED may lead to SE. Consequently, medication should be withdrawn slowly over 6 weeks to several months. Patients will need to take precautions not to run out of medication. Alerting patients of the need to follow up visits prior to the time of the medication refill can be helpful. The usage during pregnancy. In most cases, the risk from uncontrolled seizures exceeds the risk from medication, and therefore women with major seizure disorders should continue to take AEDs during pregnancy. However, the lowest effective dosage should be employed, and if possible, only one drug should be used. One AED, valproic acid, should be avoided. The drug is highly teratogenic and can decrease the IQ of children exposed to it in utero. To reduce the risk for neural tube defects, pregnant patients taking any AED should be prescribed at least 0.4 milligrams of folic acid daily. Ideally, this should be started prior to becoming pregnant. Suicidal thoughts and behaviors. The AED poses a small risk for suicidal thoughts and behaviors. Screen for suicidal thoughts and behaviors before starting treatment. Involve families and significant others in the care if AEDs are required for a patient with depression, for whom suicide is a risk factor, and assess for these concerns at every clinical encounter. Minimizing adverse interactions, again with the CNS depressant. Drugs with CNS depressant actions, including alcohol, antihistamines, barbiturates, and opioids, will intensify the depressant effects of AEDs, thereby posing a serious risk. Avoid prescribing drugs with CNS depressant properties, including opioids, barbiturates, and antihistamines unless absolutely necessary. When required, minimum effective doses should be used. AEDs interact with many other drugs as well. While some of the most important have been mentioned in this chapter already, it is not feasible to list them all. Therefore, always, always consult product labeling or use a medication interaction program to identify any possible interactions prior to prescribing additional drugs. Bringing back Dilantin. Nursing implications for Dilantin include those presented here, as well as those presented earlier. The implications that apply to all antiepileptic drugs. Identifying high-risk patients. IV Dilantin is contraindicated for patients with sinus bradycardia, a sinoatrial block, second or third degree atrioventricular blocks, or Stokes-Adams syndrome. Administration considerations. IV. To minimize the risk for severe reactions, infuse Dilantin slowly. Again, no more than 50 milligrams per minute. Do not mix Dilantin solutions with other drugs. And to minimize venous inflammation at the injection site, flush the needle or catheter with saline immediately after completing the Dilantin infusion. Ongoing monitoring and interventions. Minimize adverse effects. Again, many adverse effects can be managed by the patient. See the patient education box for suggestions to include when giving medication instructions. So here is an excellent spot to hit pause so you can review what kind of anti-epileptic drug patient education you would provide. Now see to hit pause where it most makes sense. Whether it's for Dilantin, carbamazepine, valproic acid, or phenobarbital. Dermatologic reactions. Again, Dilantin can cause a morbilliform rash that may rarely progress to Stevens-Johnson syndrome or TEN. If a rash does develop, however, Dilantin needs to be discontinued for safety reasons, and another drug should be prescribed. The risk for Stevens-Johnson syndrome and TEN may be increased by a genetic variation, again known as HLA-B1502, that's mostly seen in Asian descent patients. Minimizing adverse interactions between Coumadin and other oral contraceptives. Dilantin can decrease the effectiveness of Coumadin and oral contraceptives by inducing the hepatic drug metabolizing enzymes. Dosages of warfarin or Coumadin and oral contraceptives may need to be increased. Which brings us to carbamazepine. Its nursing implications include those presented here as well as again presented earlier during the nursing implications that apply to all antiepileptic drugs. Its therapeutic goal is to treat partial seizures and tonic-clonic seizures. It's important that we obtain a complete blood count before treatment, and it is contraindicated for patients with a history of any kind of bone marrow depression or adverse hematologic reactions to other drugs. Again, we need to screen our Asian patients to see if they have the HLA-B1502 gene variation, which again can increase their risk for Stevens-Johnson syndrome or TEN. Ongoing evaluation and intervention by minimizing the CNS effect. Because carbamazepine can cause headaches, visual disturbances, ataxia, vertigo, and unsteadiness. To minimize these effects, initiate therapy with low doses and have the patient take the largest part of the dose at bedtime. Its hematologic effects. Because carbamazepine can cause leukopenia, anemia, thrombocytopenia, and very rarely fatal aplastic anemia. To reduce the risk for serious hematologic effects, we need to obtain a complete blood count at baseline and periodically thereafter. It's also important to avoid carbamazepine in patients with pre-existing hematologic abnormalities and assess for signs and symptoms of a low cell count at each clinical appointment and follow up with appropriate lab testing if they do occur. Birth defects. Because carbamazepine can cause neural tube defects, the use In pregnancy, only if the benefits of seizures suppress and outweigh the risk to the fetus. Again, severe skin reactions. We touched on this once already, but make sure, because it can cause Stevens-Johnson syndrome or TEN, that patients with a history or are of Asian descent to test for the HLA-B1502. Minimizing adverse interactions. Because the interactions due to induction of drug metabolism, carbamazepine can decrease the response to other drugs by inducing hepatic drug metabolizing enzymes. Effects on oral contraceptives and Coumadin are particularly concerning. Patients using these drugs will require an increased dosage to maintain a therapeutic response. If they are taking Dilantin or phenobarbital, these drugs can decrease the responsiveness to carbamazepine by inducing a drug metabolizing enzyme. Dosage of carbamazepine may need to be increased. Grapefruit juice. Again, grapefruit juice can increase levels of carbamazepine. It will be important not only to instruct patients of this, but also include it in a dietary order of hospitalized patients. Your valproic acid. Nursing implications for valproic acid include those that were already presented earlier, but we'll review them one more time. Valproic acid is used to treat all major seizure disorders: tonic-clonic, absent, myoclonic, atonic, and partial, whether simple, complex, or secondarily generalized. It's important that we assess our baseline tests of liver function and identify the high-risk patients, because it is contraindicated with patients who have hepatic dysfunction or for children who are younger than 3 years of age to avoid taking AEDs. Also, we're going to avoid valproic acid during pregnancy. Valproic acid should be taken with meals, and the patient should swallow the tablets or capsules intact without crushing or chewing. We will continue to provide ongoing monitoring and interventions by minimizing adverse effects. Again, the big GI effects include nausea, vomiting, indigestion, which are common. Again, these can be reduced by taking the enteric-coated formulas and by taking valproic acid with a meal. Its hepatotoxicity, however, because it can rarely cause fatal liver injury. To reduce this risk, don't use valproic acid in conjunction with other drugs in children younger than 3 years of age. Don't use the medication if you have a pre-existing liver dysfunction, and evaluate liver function at baseline and periodically thereafter. Assess patients for signs and symptoms of liver injury at each clinic visit, and finally use valproic acid at its lowest effective dose. It also can cause pancreatitis, which valproic acid can cause life-threatening pancreatitis. Assess the patient for signs and symptoms, again, at each encounter. And if pancreatitis is diagnosed, the medication needs to be stopped. In pregnancy-related harm, valproic acid may cause neural tube defects and other congenital malformations, especially when taken during the first trimester. In addition, the drug can reduce the IQ in children that are exposed to it in utero. So valproic acid is classified in the FDA pregnancy risk group of category D and needs to be avoided by women of childbearing potential, unless it's the only AED that will work. Your hyperammonemia, combining valproic acid with topiramate, poses a risk for hyperammonemia. These drugs should never be prescribed together as dual therapy. If this should occur for whatever reason and symptoms begin, which would be vomiting, lethargy, altered levelness of consciousness, or cognitive function, your blood ammonia levels need to be addressed and monitored. And if the level is excessive, the medication valproic acid or topiramate need to be withdrawn. If not both, and another drug needs to be started. Minimizing adverse effects of anti-epileptic drugs. Again, valproic acid can elevate your plasma levels of dilantin and phenobarbitals, so levels of either should be monitored and their dosages adjusted accordingly. Your carbapenem antibiotics, meropenem and imipenem, or cilastatin, can reduce your plasma levels of valproic acid. So breakthrough seizures can occur. These antibiotics need to be avoided if a patient is taking valproic acid. Which brings us to phenobarbital. Phenobarbital. Nursing implications that apply to the anti-seizure application of phenobarbital include those that were presented under the implications that apply to all anti-epileptic drugs. Its nursing implications that apply to the barbiturate groups will be summarized in further detail also in Chapter 33. Its therapeutic goal, however, is for partial seizures and tonic-clonic seizures. IV therapy is strictly for convulsive SE. Identify the risk for patients. Phenobarbital is contraindicated for patients with a history of acute intermittent porphyria. Used with caution during pregnancy. Its oral administration is a loading dose. Schedule may be employed to initiate treatment. You may need to monitor, though, for excessive CNS depression when these large doses are utilized. IV infusion and administration. Rapid IV infusion can cause severe adverse effects, so performing infusion slowly is a must. Ongoing monitoring. Minimizing adverse effects. The neuropsychologic effects. Phenobarbital may cause cognitive deficit in children. It may also cause paradoxical excitement in both children and elderly patients. Avoid it using in these populations if possible. Assess pediatric and geriatric patients taking this drug for hyperactivity or irritable behavior. Exacerbation of intermittent porphyria. Phenobarbital can exacerbate acute intermittent porphyria, so it is absolutely contraindicated for patients with a history of this disorder. Minimizing adverse interactions. Interactions caused by the induction of drug metabolism. Phenobarbital induces hepatic drug metabolizing enzymes and can thereby decrease responses to drug metabolized by those enzymes. Effects on oral contraceptives and Coumadin are a particular concern. The dosage should be increased, and valproic acid increases blood levels of phenobarbital. Again, to avoid toxicity, you may need to reduce phenobarbital dosage. And that concludes our chapter here today. I thank you all for listening as always, and I hope you have a wonderful rest of your day. Till then, thank you for listening and have a good one. Goodbye.